Welcome to the fourth and final segment of our first QA forum of 2020. During this section, I will be discussing some genitourinary cases. Once again, I have no disclosures to report, so let's dive right into the cases. Our first case is a 60-year-old woman with abdominal pain. These are axial images from a contrast-enhanced CT scan of the abdomen and pelvis. These are the coronal images from the same patient. I'm sure you can all appreciate the dilated renal collecting systems and the post-surgical changes. Let's review our findings. We have bilateral hydroureteronephrosis and perinephric stranding. The patient has undergone a cystectomy and the ileal conduit is dilated. And most importantly, there is a peristomal hernia that appears to be obstructed. So this is an obstructed ileal conduit with resultant bilateral hydroureteronephrosis. I wanted to show this case because ileal conduits are frequently patulous, and you might not be inclined to scrutinize the ostomy site. This is a very easy finding to miss. Our next patient is a 15-year-old girl with left lower quadrant pain. We're going to be looking at some ultrasound images first, so let's review the technologist's worksheet. Of course, you should always do this with ultrasound studies because it's so operator dependent. In this case, the tech has indicated there is a large right ovarian cyst, some smaller left ovarian cysts or follicles, and a small amount of free pelvic fluid. Let's scroll through some of the images. We have some grayscale images, some color flow images, and some Doppler tracings. The tech has identified this structure in the left lower quadrant and presented it as the left ovary. There is also a Doppler tracing to demonstrate blood flow in this structure. The tech has also measured a large simple cyst in the right adnexum. With another Doppler tracing to indicate blood flow at the periphery of the cyst. In summary, the technologist concludes that the patient has a right adnexal cystic lesion without evidence of torsion and a grossly normal appearing left ovary. Recall again that this patient presented with left lower quadrant pain. Here are the axial images from a follow-up contrast-enhanced CT scan. You can see the right adnexal cystic lesion very clearly on these images. Reviewing the coronal images from the same study, once again, we can see the right adnexal cystic lesion, which is really just to the right of midline in the pelvis. Here is our large, simple cystic lesion in the right adnexum just to the right of midline. The left ovary is indistinct, and there is a structure resembling a tangle of vessels in the left adnexum. Moving to the coronal images, it now becomes clear that the right adnexal cystic lesion is associated with the left and not the right ovary. The structure resembling a tangle of vessels in the left adnexum can be followed to the left gonadal vasculature and is therefore concerning for a torsed vascular pedicle. The normal right ovary is also identified in the right adnexum on this image. In contrast to the ultrasound findings, the CT scan seems to reveal a left ovarian cyst, which in and of itself could explain the patient's left lower quadrant pain. In addition, there are findings raising concern for possible left ovarian torsion, which is of course a surgical emergency requiring a phone call to the referring physician. I wanted to show this case to demonstrate some of the pitfalls of ultrasound interpretation. The performing sonographer's impressions are essential, and I frankly won't dictate an ultrasound case without a worksheet from the technologist. But it's also vital that each radiologist approach the images with a fresh perspective and formulate one's own opinion. Here is a companion case of a 39-year-old woman with right lower quadrant pain. Let's scroll together through these axial images from a contrast-enhanced CT scan. Here are the coronal images from the same study. I think the findings are much more impressive in this case. The right ovary is markedly enlarged. It is also edematous with some para-ovarian fluid. And there is twisting of the adjacent vascular pedicle. This constellation of findings is consistent with ovarian torsion, and you probably don't even need an ultrasound for confirmation in this case. I'm sure you can all appreciate how easy it would be to mistake this finding for a large pedunculated subserosal fibroid. Our next case is a 51-year-old woman with abdominal pain. Let's review the axial images from a contrast-enhanced CT scan of the abdomen and pelvis. And the corresponding coronal images. On this axial images, there is a very subtle focus of renal cortical mottling. I'm sure you can all appreciate how easy it would be to miss this finding when scrolling through the axial images. But I think you'll agree that the findings are a little more conspicuous on the coronal images. This, of course, is a case of mild or early acute pyelonephritis. Given the subtlety of the findings and the fact that we so frequently lack localizing information, as was the case here, you can probably imagine how often this diagnosis is missed. I also wanted to use this case to reiterate the importance of reviewing the sagittal and coronal reformatted images when interpreting CT scans. I can't tell you how many things I pick up there that I missed on the axial images. This next case is an 84-year-old man with right-sided abdominal pain. As we scroll through the axial images from this contrast-enhanced CT scan, pay particular attention to the renal collecting system. As we scroll through the coronal images from the same patient, be sure to compare the upper pole moiety to the lower pole moiety. There is prominent soft tissue attenuation in the upper pole moiety of the right renal collecting system. The contrast between the appearance of the upper and lower pole moieties is impressive on this coronal image. This is a case of transitional cell carcinoma, which we're much more accustomed to seeing in the urinary bladder and ureters. It's easy to overlook when it occurs in the renal collecting systems. This next case is a 36-year-old woman with vaginal bleeding. This is a static sagittal grayscale image from a first trimester ultrasound, and the technologist is measuring a small hypoechoic crescentic area adjacent to the gestational sac. Here is the corresponding transverse image. I'm sure you all recognize this as a small subchorionic hematoma. A couple of teaching points that arose from this case: the sonographer did measure this finding, but neglected to include it in the worksheet, so always make sure that you check the worksheet and carefully review the images. In addition, there is some difference of opinion in how you measure these subchorionic hematomas. Right now, the consensus is that you should compare the size of the hematoma to the gestational sac, and if it's more than 50% of the size of the gestational sac, that qualifies as a large subchorionic hematoma. I was taught that you measure the circumference and how much of the circumference the hematoma involves, but I think either method works. Our final patient is an 80-year-old man with lower abdominal pain and bloody urine. These are axial images from a non-contrast CT scan. This is not an eye test. Here is a single axial image demonstrating the large bladder mass with associated blood products. Upon review of the bone windows, however, we also can appreciate this destructive, permeative lytic lesion in the right iliac wing with an associated soft tissue component. This is a metastatic lesion, likely resulting from a primary bladder tumor. This is a demonstration of satisfaction of search. We are given a history of bloody urine, and there is clearly a large mass in the urinary bladder, but it's very important to go through your entire search pattern and review all the various windows and all the reformatted images so you don't miss any important findings like this lesion here. This concludes our first QA forum for 2020. Thanks to everyone who attended these sessions. I hope that you found them useful, and I'll be looking forward to our next session, which should be sometime this summer. Thanks again, and take care, everyone.